Today's conversation explores what becomes possible when pediatric care is designed around the real lives and needs of families. We're joined by Dr. Marianne Woodruff and Rachel Lettieri of Pediatrics Northwest in Tacoma, Washington, a practice nationally recognized for integrating behavioral health, community health workers, literacy, and family partnership into everyday pediatric care. Dr. Woodruff is a longtime pediatrician and nationally recognized leader in community pediatrics who helped bring Reach Out and Read to Washington and has spent decades advancing the medical home model. Rachel Lettieri, Director of Care Transformation, brings a deep background in children's mental health and social work, helping lead Pediatrics Northwest's innovation and family-centered care model through initiatives like Pediatrics Supporting Parents with 0 to 3. Together, we talk about what it really takes to support children and families upstream through trust, prevention, belonging, and systems built with families, not just for them. It is such a pleasure to be joined by Marianne and Rachel from Pediatrics Northwest. Marianne and Rachel, thank you so much for joining us. We're so excited to talk to you today and dive into the incredible work of Pediatrics Northwest. Your organization is a regional multidisciplinary pediatric group dedicated to improving the health of children and families in the communities that you serve. It's been a pleasure to get to know you, and I'm so excited about this conversation and the opportunity to show to the world the incredible, passionate, excellent badasses that you are. So let's get started.
Yeah, it's so wonderful to have you both here, and we've had the pleasure of seeing you all in action, serving families, changing systems, and doing that with both grace and just an energy that is infectious. So we're so happy to have you and share your story and how you've done what you've done as an inspiration, and hopefully we can share some playbooks for how people can make important things happen for kids and families. We'd like to start the conversation with why. Why did you get into this work? Why do you do what you do?
Well, I'm Marianne Woodruff, a general pediatrician who saw patients for 36 years at Pediatrics Northwest, and now I get to serve as the medical director of Care Transformation. And I think those words hold the clue to the why. It's being a pediatrician was the dream all of my life from the time I was 8. I could see the power of it, and I was surrounded by people who just deeply cared about others and thought, that's what I want to do too. And then the why morphs so over the years, right? When you realize oh, this can be better. We can do this better. And then that why, it just led to so many yeses. And the yeses, and one of the most powerful yeses was the one that led us to you all, to say yes to being a fellow in that hub. That was the game changing. And so that we could really put into practice what we had hoped for all these years with caring for patients. So that's, I say, for the first 30 years, I did it in a way that the best I could, and deeply caring about families. And now we're doing it in a way that the families themselves wanted.
I love that. I'm just picturing an 8-year-old Marianne with just so I can see you with that why and that spark. It's beautiful. Rachel, what's your why?
My why, so I started the first 10 to 13 years of my career doing intensive family therapy, mental health in the mental health field. And it's very taxing and rewarding at the same time. And what I realized is just how siloed the mental health field is and therapists are, and how just behavioral health challenges for some reason are being treated in isolation, although it's not. It's all interconnected, physical, mental. And so starting this opportunity to build at Pediatrics Northwest, to build a community health worker division, to really have people of the community to accompany families at a universal touch point, such as the pediatric medical home, to be able to bridge those gaps between mental health, physical health, unmet health-related social needs, and just bring it all together in an accompaniment model of a team of carers. It just it changed everything for me. I felt like I was transforming how I was thinking about healthcare and kids' behavioral health, developmental needs as I was kind of unfolding with this position. So, like Marianne, my why has changed and blossomed, and it's continuing to. So, it's staying very exciting.
Thank
Some
you
of
so
it
much
is
for
why
sharing.
not?
Oh, I love that. I love that. We should ask Jason. We should ask why not, right? So after I met you, I'd imagine Jason felt the same way. After I met you and heard about the vision that you were enacting at Pediatrics Northwest, I wanted to march into my pediatrician's office and say, like, I want it like this now. I didn't know that this could exist. So, Marianne, you know, Pediatrics Northwest has been working with children and families for more than 50 years. And we've worked together a lot on storytelling. So I'm going to put you on the spot and ask if there was a particular moment with a patient or a family in the clinic where you realize that the existing system, the system that is true for so many of us, wasn't meeting kids' behavioral or developmental health needs. Tell us about that moment. I'd imagine you have many of them.
There's many. I think one is really almost from the start of my practice, and in a trajectory that actually spanned almost the whole time I saw patients. And it's not one that is particularly happy. Um, a mom who had 5 children and all ended up being raised by relatives other than her. And I had the ability, I took care of 4 of them. Many of her siblings stepped in to help. But the eldest one, actually I met as I went to a resuscitation at the delivery, and the baby had neonatal syphilis. We're hearing a lot about that right now because it's recurring, but it was also true in the late 80s. And we were able to successfully treat this precious little one. But she was just one of the 5. The 4 who were being cared for by various aunts and uncles, they blossomed and were doing developmentally well. But the eldest didn't have the same opportunity. And mom was just caught in a vortex of substance use concerns. We always wanted to help. And in fact, one of the saddest things was that when she delivered the other kids, she had such shame that she literally ran out the door of the hospital shortly after delivering. It's heartbreaking and it's not inevitable. And unfortunately, the eldest daughter then experienced some of the same things. And all that happens without people really understanding like the whys of it. And it had been generational, but not. And so like, how do we help everyone in our country escape like the judgment part of this and just standing in awe of like what people are trying to do? And I feel like if I could have a do-over right now, that team of community health workers that Rachel just mentioned from the very start could have got the help, because mom wasn't opposed to getting help, but it wasn't there in a timely way. So I think about them a lot, and I think about so many others. One other family, the twins, one with stark developmental differences, and the mom, it changed the trajectory of their lives. They have all the means you could have, but that doesn't matter in a system that doesn't take into account children who have other needs. It barely takes into account those who don't. And that the daughter is now 22, and this was one of the last families I saw before I transitioned from seeing patients. And mom said 22 was like the first year of life. It was like another little death that she experienced because all the resources go away. That school systems stick with you till you're like in Washington now till the day you turn 22. I think about them all the time, and I think about the work in the community. The first playground in our community that was for all abilities, it was this family's tireless efforts that did it. And I would do anything for them, but it was never enough. And I feel, again, if I could do a do-over now, it would be different.
Thank you for sharing that story, Marianne. It's so beautiful that you said standing in awe of people surviving, right? Like that's such a beautiful way to say it. and without judgment, which is exactly what you do. Rachel, so you work with the workforce and the community health workers and the amazing people that are in your clinics every day. What, from your vantage point, did you see happening repeatedly that made you think we have to do this differently?
Yeah. So I started off as, I guess you would say, the first community health worker, and really building this as I went and establishing uh, workflows. And so what we kept seeing over and over again were families coming to us with complex needs that were never purely medical. So as I started as a community health worker, care coordinator, navigator, it's synonymous, but a child that came in with their family might be showing developmental delays, behavioral dysregulation, or anxiety. But underneath that, there were often things that the pediatrician themselves were not able to address for time, not for lack of caring, but lack of time. And often those things were food insecurity, caregiver stress, lack of childcare, difficulty navigating systems like early intervention or behavioral health. And they didn't know how to ask, or that was even a safe space to ask for support in those things. And what was really striking to me is that families weren't failing to follow through on different resources that I was providing them because they didn't care. They were actually trying really hard. They were just trying to navigate so many fragmented systems that weren't built to work together. And so we really had to retrofit kind of a model that is not built for team-based care and is not built for kind of this relational team of carers and team-based care in general. And so what we realized was that pediatric care needed to do more than just diagnose and refer. We really needed to help families navigate the systems, reduce stressors, and strengthen relationships, and relationships being one of the first things we do, because those are the conditions that allow kids and youth to thrive developmentally.
Every time I hear you all talk about the work you're doing and the impact you're having, I think your earlier point of why not, it's just like, why not everywhere? Like if you wipe away, all the barriers and you just think at a very human level, like how do you connect with folks in a non-judgmental way and support them in their core needs? And you all are activating that in every day in all sorts of complex situations. Can you speak a little bit about the barriers that you faced when you first found this unlock, right? You bring in Rachel, she's this first community health worker, you're shifting your approach to really do all those things. Like what were some of the key barriers initially that you ran into to make this work within your team at the practice?
Well, it started with what Rachel said, that the system itself is wrong. And so that we had to look at retrofitting a very poor system that was never made for teams of care. I've been reflecting on this a lot lately too. My dad is a pathologist. Ultimately, he was a family doc initially. And when he was on call every night, my mom would be calling him to tell him which house he was going to do the house call at next, where he should go. And I think about what he had to offer. He had to offer penicillin, some sulfa, doing a blood pressure, vital signs, an exam, human touch, and in the home of people. So it was abundantly clear that people were in relationship with other people. So now we're really, really good at this technological, individualized care, but left out the relational context of people's lives. So just the way it's framed, in that the system is more like a conveyor belt, one size fits all. It's like children and visits are like fruits going across the conveyor belt at the grocery store. But that couldn't be further from the truth. So that's barrier number one. Mm-hmm. Barrier number two, that was a huge cliff for us. Where are funds to have a runway to give time to think deeply about this and then to plan? And that's what a small grant from the Medicaid waiver allowed us to do. Collaborative care, behavioral health integration, in 2018 and 19, had a 1.5 year runway before we saw the first patient. I'd had all these ideas, and pediatricians have plenty of ideas, but there isn't the time. And there is no pathway currently that allows for that to happen unless you're in some academic centers. And then my academic colleagues are just overwhelmed by the breadth of things that they have to do. So that was first. And then, Rachel, what do we always talk about? Practice wellness. The wellness of the people being subjected to being at the front line of what they want to do, but in an impossible system where they're told, just see more, just see more. And so it turns out, unless we address the wellness of the people, and then it's iterative, right? The more you can do these changes, people are more well. But Rachel, like, this list could go on.
Well, yeah, I think that practice wellness is a big part of it, but then also it allows that mindset change to really benefiting from the wisdom of the community as opposed to just inviting the community. Like, we should be fortunate that the community invites the medical space to be able to benefit from that. And so I would say another barrier was cultural. Like, healthcare is used to thinking of the clinic as the center of care and the one with all the answers and the magic wands, et cetera. And what we're proposing is shifting that mindset and recognizing that a lot of what shapes child development happens outside of the clinic walls. Who knew? And so building that bridge between healthcare and community systems took time and partnership and a willingness to rethink traditional roles.
I have to say one more really important one.
Please.
And the emphasis, if you even look at like how we learn how to do what we do, there's a huge amount of learning to understand different disease states, what's their trajectory, et cetera. But if only people talked more about, and I did have it in medical school. So I think it's why I ended up where I am, because who I was taught by emphasize listening and healing and not just fixing. And there's a lot of pressure on clinicians to think about and to come up with fix-it ideas instead of, just as Rachel was saying, families, especially in wellness visits, they have the answers. They know, they want support. They want to hear like that they're doing something well, and no one gets to hear that enough as a parent.
Amen. I'm struck by just how many barriers existed when you first started this and still exist. And then thinking about, I picture, I'm old school. I picture I Love Lucy and the chocolate assembly line. How'd you step back from the chocolate assembly line and, you have Rachel in place and you all are shifting, but how did you go from just getting through the day to really bringing to life all these things? Like, if you could go back in time and think about some of those key strategic choices, what were some of the ones you would share with folks trying to think along the same lines?
I can talk a little bit. So one of the hardest choices that we had to make early on was really to stick to the vision of what we were trying to build, because it was so easy to just like scale a program by saying, okay, each community health worker needs to see 15 families per day, and just like completely just do what it like traditionally has always been done. Or, okay, we need to have X amount of billable minutes per day in order to sustain the program. And instead, we said, you know what? The non-negotiables are that we need to build something relational, and there's absolutely nothing expeditious, I would say, about that. And that's okay. And so preserving the things that mattered, like, for example, we have one day a week that our community health workers are out there in the community doing outreach, building relationships with the resources that they're connecting families to. That's not billable time. That's time that we've chosen to say that this is important to the integrity of this role and ultimately to know what's out there for relationship building, and this sticks. And so we've been doing this for 4 years now, and they still have that time. And we are billing Medicaid for their services, but we still have stuck to they need this non-billable time in order to maintain the integrity of what this role is, and that's relationship building.
And we stuck to the vision because we had that runway of time to think about it and to be connected. Like the dance of connection in this work has been enormous. And the dance of connection with the fellowship was beyond game changing.
Mm-hmm.
In that and the possibility always knowing about repair, right? Because whether it's in our relationships with our children, with our spouses, with our friends, with anyone, it's about when you can repair there and you know that that's a possibility, then there's joy too. So ultimately there was just utter joy in this work of saying, what if it didn't take 26 phone calls for a parent to seek one mental health appointment? What if it didn't say in the chart when someone didn't show up to an appointment, failed? What if we thought about it through a whole different lens, like from the families, and it was sitting right there, right in front of us the whole time? And now it's iterative. Just listen to the families, right? And what they're enduring, and then stay true to these goals of like combining the best science about relationships. And that doesn't everything come down to like relational well-being? And
I think this is a pattern we see over and over again in the work we do at the fellowship, is that you have to be dogged. I'll use a word that may not usually be used in this space, but
love
ruthless
it.
about holding to your vision, holding to that relational approach, because otherwise you'll get swept up in the barriers, the other incentives. And so I think that's a great for both of you to share that. And it's not like, money's raining down on Pediatrics Northwest. Like it's not like you have some unique resource advantage, but you have this cultural and values advantage that you're ruthless about delivering on, which is just so inspiring.
We're efficient where we should be efficient, but I don't see relationships as being efficient, nor should they be. And that's been the problem all along, is that pediatricians are told, just one more, just be efficient. And that comes at a price. But when you're able to do this in a team-based way, it changes it.
I love that. You'll appreciate this about me, Marianne and Rachel, because you know me, but my like deepest held belief is that people are good and more people together are better. So a couple of days ago, I was like, I'm going to speak to 1 million people. My like hobby is going to be, I want to have 30-minute conversations with 1 million people. And so I'm talking to my friend and he's like, okay, like what kind of time are you blocking on your schedule? I was like, let's say 10 hours a day, 7 days a week. This is just my mission. Turns out that would take 137 years. But I think I so deeply resonate with there's many different places and many different ways that we can be efficient, and relationships and people are not one of the places we should be looking for efficiencies.
Mm-hmm.
And instead depth, connection, understanding, curiosity. And I think you and your work both represent that so perfectly. So let's talk about what surprised you about what families actually needed versus what the system felt like they needed. Was there were there assumptions in there that were proved wrong or right? Because it seems like in your work, in many of these systems change work, there's a tension between the assumptions and the reality for families.
I think one assumption we initially had, correct me, Marianne, was that if we built better referral pathways to community resources, that would solve all of our problems, or a lot of the challenges at least. And what we quickly learned is that referrals alone are rarely enough. You can't just, as Marianne says, like fingers crossed, like hope you get connected. But families often need someone to walk alongside them and to accompany them and help them navigate applications, understand systems, follow up, check in, and sometimes just building the confidence to engage with services or to make that first call. And that's really where the role of what we've built with community health workers, it became so powerful, is that shifting the model from simply handing families information to actually supporting them throughout the whole process.
I think the other shocker is just the utter friction that exists. for families, and when you start, and then it's worse for some who and I think about Jay Chowdhury, who we met through the fellowship at Sagamore Institute, when he said and wrote about, isn't it interesting that for teenagers to do online gambling, it's completely frictionless.
Mm-hmm.
But try to get an appointment with the rheumatologist.
Mm-hmm.
Try to get a mental health appointment for your child. It's just friction filled. And for some, it's just there's cement blocks in the way. And that is unconscionable, and it makes no sense, and totally has solutions, right? So if you can do this thing where about making it easy for these other systems, then this can be addressed too. And that's what we're seeing. And Maya, to your point, but with its technology assisted and supported and accompanied by a relational care.
Mm-hmm.
That's the key to it.
Absolutely. And I mean, you two are the key to it, but yes, that's another key to it. So once you saw what was possible, once you knew that it could be different, did you just start running around town being like, it doesn't have to be this way, here's a different world? Like, let's talk about the storytelling piece of it. I know this is a place that I pushed you sometimes to get uncomfortable and share the stories, but how did the narrative shift? You know, even just the language that you use when we hear you, right? You talk about a community of cares, you talk about community health, you talk about well-being, you talk about relationship. Um, how did the narrative shift from the world of clinical jargon to where you've landed, and what's the response been?
I think initially the story was about improving behavioral health access in pediatric care. And then over time, it came clear it was really about supporting the environments that shape family mental health and children's well-being, family relationships, caregivers, community supports. Um, so the story shifted, I would say, from a more narrow focus on clinical services to a broader vision of pediatric care being the platform for family well-being and early relational health. Um, and we started looking, well, I started, Marianne started way before me, but realizing that at the pediatric medical home, there's a unique opportunity of a trusted entry point for families, because the reality is that families, even if they're not getting their own care, seeing their own family doc, they're going to go to their appointments with their kiddos. And nearly every child interacts with the healthcare system, especially in those early years. So it creates an opportunity not just to treat illness, but to strengthen the conditions that allow children and families to flourish by supporting that thriving.
I'll just say it, one more way in which, like, being in relationship with the two of you and our fellow fellows was changing how we saw ourselves.
Yeah,
It,
right.
it seems ridiculous. I did not see myself as powerful as a pediatrician. I did not. I saw myself as a very caring person who wanted to serve families. I see myself in a different way. And once you see yourself in that other way, you can share it with others. And so I think that is the other part of this storytelling, became bringing others along with us to tell their stories and elevating their stories, because there are a lot of people who never get to tell their stories.
Mm-hmm.
And then we shifted from saying we're in the process of reimagining to saying we've reimagined it, and that we boldly now say with data that it's efficacious, having team-based care, it's feasible, it's scalable, and we have data to support it. I mean, that's really, it didn't say that initially, but it started with doing chunklets at a time. And the thing we say, once you see what families are experiencing, we can't unsee it. And we can't unsee the need for their voices to be at the table and to convene the table, really. So
Can we go back a minute? Because I think you said something so, I think, profound that innovators in this space need to hear. You and Rachel, I don't want to put words in your mouth, but I imagine you had a similar switch happen in thinking about where you stand in this space and
Mm-hmm.
what you bring to the broader community. Could you go a little deeper in on like what was the switch? Like what got you from going from, you know, Marianne before Maya worked with you and the other fellows worked with you to like the badass entrepreneur that you've always been and you are now, and channeling that?
Never would have applied to like speak and do workshops at conferences or to do posters or press releases or put my name on a white paper. Like that never crossed my mind as being something that like I could have obtain. It wasn't necessarily, it wasn't just on my radar. I knew we were doing good work. I knew that we like were doing innovative work. But I don't know if it was lack of confidence or what, but it wasn't until this fellowship in particular and working with Maya and getting her to perfect my story personally, not just professionally navigating this position, but um just encouraging us, calling us badasses certainly helped. But I think that it really it allowed me to have the confidence and the connections within Thrive and Georgetown to realize like, yeah, you know what? Like we are doing something really cool and people do need to hear about this and people do need to know about this. And we're in a position now to help people. And that's exactly what we need to be doing. So yeah.
Go back to a phrase that I first saw in about, I think the book was written in 2018 about social infrastructure. And it referred, these two words, collective effervescence. And I think it was a French sociologist named Hubelin who first coined that, but then it was put into this book. And at the time we were working on collaborative care and we sat around this table and we're planning it for that year and a half. And I just came in one day and I go, this is what this is. It's collective effervescence. Because when you're with like-minded people who are rowing together and you're not seen as like silly. I mean, it sounds so stark, but really like kind of dreamer, silly. Yeah, that's nice. That's nice. I mean, I feel dang fortunate in my life, but there are times when people can be dismissive. And nice, I think nice is a choice. I think being in a relationship, that is clearly a choice. And then the accelerant was being in the fellowship where people were so deeply listening to it and heard things that we hadn't heard ourselves, right? And to have that reflected back to you, I mean, I could weep right now, honestly. I mean that, you guys.
We love you, Marianne, and we are so grateful for the impact that you have in the world. I think it's really important to note, Rachel, what you said, right? About like, I was just put my head down and I was doing good work. And there's so many folks who resist what they see as unnecessary or unrelated, or just simply things they either don't know about or don't have time, right? But I always think about, you never really know who's watching you and what they can learn. Right? And the model that you've worked so hard to build at Pediatrics Northwest is what should be scaled nationally and globally, right? And it can only be done through storytelling, through thought leadership, through telling people about it and writing those press releases. And I think that you represent a really important evolution in so many of the entrepreneurs that I know, that Jason knows, when you understand you're actually not doing it in service to yourself, right? You're not getting it so that Marianne Woodruff, pediatrician, is in the news, right? You're doing it in service to the people for whom and with whom you work. And when you change that frame, right, it makes such a big difference. So thank you for calling out that important distinction. Jason, I'll turn it back to you.
Today.
Yes, I'm happy to tell you anytime.
We all need Maya in our on our shoulder as we're going along the day. So thinking about I imagine you're getting pediatric practices in Washington and beyond coming to you and saying, how the heck do I do this where I am? What are you saying to them in the hallways? What secrets are you sharing with them?
So much.
Yeah, I mean, so much. That this is doable, and there are enough of us now doing this. Just come along. I think there's famous painting that just shows all these people walking with their lights at night. I think it's Scandinavian, coming together. And that's how it feels right now, that people want to be on this journey. They want to do it. And then there are ingredients for that to happen. And those ingredients include, don't panic, that you can do this bit by bit, but it all comes back to having that notion, like, it can't be just business as usual. And then we have recipes for this, because you're right, we are helping a variety of people. So we listen deeply to kind of what they're saying, where it might work. There's one that is really kind of surprising recently, where I would say many of the people we're talking to, they'd never thought about community health workers in primary care in the way that we're doing it. And many are doing collaborative care. And then they heard this, and one of them literally goes, "We have to get off this meeting right now." And then came back to us and said later, and they said, "We've changed the whole way that we're going to approach this. Can you talk more about that? Can we meet this mystical person called Rachel?" Yeah, you can. And I think we try to be really generous with our time, knowing that so many people were generous with their time with us, so many, and continue to be. And so we say a lot of yeses, and then just try and find that place. And Rachel, like, go for it. There's so many ideas.
I think a couple of things that we tell, like, pediatric practice in general. So often the solutions already exist in pieces. You just haven't connected them yet. And we try and say, like, be willing to learn as you go as well. Like, transformational models rarely emerge fully formed and thought through, and they evolve through iterations, PDSA cycles, partnership, iteration, trust. And I think that that's hopeful to hear when we talk to other practices. And I think also just the reality of being reminded that healthcare systems are complex, and they often change and move slowly than you would like. But I think one thing is that transformation and really seeing and doing things differently is worth it. And it starts with small, practical innovations that demonstrate what is possible. And then once you're demonstrating what's possible, and clinicians and families see, oh, this is better, and things start moving more smoothly, that is when momentum builds and collaboration and coalition building happens. And that's what we've found over the past few years. So yeah, I think, and just always sticking to why it is you're doing what you're doing. And for us, it's, children's brains develop in relationships, not systems. And so our systems have to catch up with that science.
And we're making a big effort to really discuss how important family leadership is. When I look at the history of pediatrics, almost all the huge things that happen as a result of someone somewhere deeply listening to parents, and often to parents of children who had chronic illness, different disabilities. The whole idea of even the medical home model started in 1965. As people went to a Hawaiian pediatrician, and Calvin Sia listened in a whole different way. George Tambera, who founded our group, is in that same cohort of people, and he did the same. And so if families aren't centered in this in a different way, and it gets back to Rachel's comment about, we need to humbly ask to be invited to the community as the medical system, not being a place with a moat, saying you're lucky if you get across.
Okay, so you all are, just bringing so much hope here. But yeah, if you finished that secret sharing session with them, what do you challenge them to do? Can they do this in a month, in a week, in a year?
I think that creating team-based care and starting your journey with relational teams is possible now. Taking that first step to build that model and embedding them in pediatric primary care is something that can be done right away. There are mechanisms that can fund part of their salary. And as far as family partnership, that's there are ways to kind of take the first step on that, but there isn't a full way to fund something like that de novo. So,
I think that's where our leadership really has a big focus. And
yeah.
that's one of my goals is to just say to huge systems, to Medicaid payers, to the MCOs, to everyone, like this has to be funded the same way that other things are funded. But face it, we're in a system where one person's on the medical team's actions are paid for. That doesn't, I mean, like the fact that we've been able to get this far is remarkable given that. I know, I mean, it's just, so we persist. And I think there are steps that people can do that don't take, like even just doing appropriate screening and just having medical leadership saying, if you're going to ask these questions, you have to address it with the family. You could say, I don't have an answer right now, but I'm going to look for it. But so many people just are perfunctorily screened and no one ever says anything to them. And probably the four of us have had an experience like that. And so there are simple changes that can happen and we can get there. And we're seeing it, like the Washington chapter of the American Academy of Pediatrics is doing a lot of work along these lines. People want to hear about this, and they want to do it. And so, like Fred Rogers said, look for the helpers. Okay. I mean, it's just so true. I mean, there's a lot of us that want to help.
As you both know, I get tattoos based on like inspiring things. I just want like Marianne quotes up my arms. It's
too.
just, it's incredible. So, okay, we're getting to the end, and I'm going to put you both on the spot because you are thought leaders and influencers and leaders in the behavioral health space. And in order for us to achieve the world that we know is possible, we need to invite other people to find their role within it. So, how can people connect to, support, invest in, and learn from your work at Pediatrics Northwest? What invitations would you leave folks with?
We have a beautiful landing page that just came out this week as a result of our Pediatric Supporting Parents grant that just ended in December. And it's a sub page off of 0 to 3's website. And I would encourage people that are looking to make this first step to view that and the remarkable innovations library that they have there. From both us and the 4 other proof point communities that did innovative work in pediatric care as a starting point.
I think also looking at the American Academy of Pediatrics is more deeply thinking about these things and is doing really good work and connecting. Some of the chapters around the country are really focused on this. I think it sounds silly, but looking at some of the policy papers, some of these things are outlined so long ago, right? But now it's about doing it. I would encourage the other people I really, 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 really want to talk to are health systems leaders and say, this investment that might look like the challenging is the one that will actually, from which you would reap the most benefit. Do you want less staff turnover? Staff turnover is really expensive, whether it's pediatricians, nurses, therapists, OTs. When people feel so beleaguered, they cannot stay. And so simple investments in family partnership, in team-based care. And so that's like, that's not something someone else can necessarily do, but I think how do we work together to do that? And I think reading, whether it's reading fiction from authors that you have not, from different kinds of people other than you, game changing. Right?
We can't leave this conversation without a book recommendation. For what do you have for us along those lines?
Oh my gosh. Well, I'm reading The Correspondence right now because there was so much buzz about it. And it's super interesting because there's some other kind of funny books I've read, but this one, it's about how you don't know about, it's about repair. It's about relationships centrally, and that how you see something at one phase of your life may not be how you see it later.
Yeah.
It's It's super interesting.
It's a great book.
And then
Well-
Consolations, that book, Jason, I've now given so many copies. I think that David White is onto something, and how he really digs into what do words mean, and in just such a thoughtful way. And Anything by Colson Whitehead.
If you haven't realized by now, we love getting book ideas from Marianne. We'll share these in the show notes because I think they're always like fascinating reads. But I think tagging back to your point, Marianne, like they open your mind in ways that are required to best serve people, kids, families, and we just want to share a deep level of gratitude and. I always come away from conversations with you with a deep sense of awe in how you do what you do and how you bring it to life. I wish I could talk to you both on a much more regular basis, but just like the thing I reflect on in this conversation, there's so much goodness in there, but that earlier point of like having a ruthless vision and set of values anchored in this relational approach in a family-led way, that's not free, but it's possible if you hold that tight. And then to both your points, but Rachel, I really love how you brought to life the take the small steps, because those small steps leading towards that vision create energy. They create energy within the team. They create energy with the families, and that energy is the fuel to get through all of the barriers. So thank you both for doing what you do, and to the broader Pediatrics Northwest team. I know there's so many awesome people doing that work every day, and thank you for taking your time, your precious time, with us to share your stories for others.
Just enormous gratitude right on back. And can you just imagine, like, as you imagine, because now I want to just spend an hour interviewing the two of you, as you thought about, I'm serious about this innovations hub, this fellowship, like in your wildest dreams, like this is so remarkable, and I can't convey that enough. And now that Rachel and I are connected, I think in some way meaningfully with almost every single one of the fellows, we in an implementation way, like this is the best kind of magic. And so the awe is returned to how I feel about you all.
Thank you so much. So good to see you.
Thanks for having us.